All right, so we are about to get into section 12, and it is titled Psychological Effects of Witnessing a Traumatical Clinical Childbirth Event Amongst Midwives in Niger State. For our presenter, she is a midwifery educator from the Department of Nursing Science, Ahmadu Bello University, Zaria, Kaduna State in Nigeria. Her specialty is in maternal and child health nursing, with her research on traumatic childbirth and its implication for psychological well-being of midwives and midwifery practice. Her academic interests include maternal health, midwifery education, and improving supportive care for midwives who witness aftermath of childbirth-related trauma. She is in the person of Dr. Amina Ahmad. Doctor, your audience.
Thank you very much for that wonderful introduction. Good morning to everyone in the house. I still remain Amina Ahmad. I'm here this morning to present you a work on psychological effects of witnessing a traumatic clinical childbirth event among midwives in Niger State, Nigeria, with my co-authors, as you can see on the screen. Yes, next slide, please. Next slide. Prof. Sadique, next slide. Okay. So by way of introduction, midwives frequently encountered obstetric emergencies that may result from injury and this constitute a psychological burden on them. A traumatic event. Sadique, we are not on the same page. I am still on the first page. So a traumatic event is an unpleasant occurrence that can stem from injury, violence, or emotional shock. Despite childbirth being positive experiences, but sometimes you find out that complications can arise, which places the life. Yes.
Yeah, it looks like the slide is not moving.
I'm actually at
still on
statement of the problem.
No, I'm still on the introduction.
Okay.
I'm still at introduction.
Thank you. Yes, I will reset it and download it.
I'm still at introduction.
You said?
Please, are we on the same page?
Yes.
Yes, we are.
Thank you.
So as I was saying, I said, despite the fact that childbirth can be positive, but sometimes circumstances and conditions can come up whereby you find out that traumatic events can occur. So even though the trauma directly affects the mother or her baby, but the midwife who provide care and support is equally affected by this trauma because she is there witnessing the event when it occurs. So midwives during childbirth, they experiences a range of emotions from joy to gratitude and sadness to anxiety in cases of traumatic birth. So such traumatic events can lead to burnout, emotional exhaustion, conflict, and this can impact their interpersonal relationship, causing them to have symptoms of post-traumatic stress. Next slide, please. Next slide. So these are some dramatic facts from Nigeria. In 2019, Nigeria was ranked first with about 512 maternal deaths by 1,000 live births and a neonatal mortality of 41 deaths per 1,000 live births. This means that in every 25 deliveries, one of the neonates will die before his first birthday. At the zonal level, that is at the central zone, 28 neonatal mortality is being recorded by 1,000 live births. And this central zone is where the study is being conducted. And then half of this death occur within 48 hours after the delivery. In the northern geopolitical zones, this contributes about 84% of the mortality under the age of children under the age of 5. And with this statistic, it means that midwives who are there during the childbirth witness and are being exposed to attending to traumatic deliveries. Next slide. Next slide. Okay, this brings us to statements of the problem. You want to believe with me that universally the working conditions of midwives has been described as stressful, and it can be even more demanding with attending to traumatic childbirth events. In low resource setting, the burden of traumatic childbirth experiences are on high increase due to factors such as high maternal mortality, limited access to prenatal care, and the prevalent socio-economic and socio-cultural disparity. So despite the limited research on midwives witnessing traumatic childbirth, I want you to believe with me that a report by the Nigerian Demographic Health Survey reported that about 46% of childbirth is being attended by skilled birth attendants, and these skilled birth attendants are the midwives. So therefore, midwives are being exposed to traumatic childbirth in each and every day of their work space. And even though these traumatic childbirth experiences are known to occur, but there is little empirical studies in low and middle income countries, especially the northern part of Nigeria, on how midwives witnesses this event and how it impacts on their mental health. So that was the need for this study. Next slide. So the aim of the study is to examine the perceived psychological effect of witnessing traumatic clinical childbirth events by midwives working in secondary healthcare facilities of Niger State, Nigeria. Next slide. Next slide. So we are in a material and method. The research design that was adopted for this study was a cross-sectional study design. It was used to gather information on the psychological effect of witnessing clinical traumatic childbirth event. And the study area is Niger State. It's one of the 36 Nigerian states that was established on February 3rd in 1976. And it shares some border with Abuja, Kaduna, Kogi, Kwara, Sokoto, and Zamfara State. So the study setting, Niger State is divided geographically, political. The vision of the zones were in 3. So in each of the zone, one hospital was selected for the study, as you can see on the screen. Next slide. Next slide, okay. For the population of the study, midwives that are working in the maternity wing of the selected hospitals were utilized, and there are 160 in number based on the information received from the Niger State Hospital Management Board. And the inclusion criteria were midwife, qualified and certified, working in wards such as antenatal ward, postnatal ward, and gynecological ward. The exclusion criteria are those midwives on study leave or on sick leave on the day of the data collection. Next slide. Next slide. Okay, the sample size estimation. This was done by utilizing all the midwives because of their manageable number, as I earlier mentioned. They were 160 in number. So all the midwives in the maternity wing of the 3 selected hospitals were recruited for this study. Next slide. Next slide. Okay, so the sampling technique. These are the processes followed to come up with the hospitals that were used for the study, because Niger State has a total number of 26 hospitals in all. So we utilize a multi-stage sampling technique to come up with 2 stages, that is selection of the hospital and then selection of midwives. For selection of the hospital, the first stage we used was the clustering sampling. We used it to cluster the Niger State into the existing 3 geopolitical zones. As you can see on the screen, we have the Zone A, Zone B, and Zone C. Then we use a simple random sampling to randomly select 1 hospital from each zone. And the reason for the selection of this hospital was because these hospitals were located in the most urban local government within the zone. They have the highest number of deliveries, and they have the highest number of midwives, and they have serves as a referral center to nearby local governments surrounding the area. So that was the reason why this hospital were selected. And then coming into the hospital, we use a purposive sampling to select the maternity unit, which is the focus of the study. And then for the selection of midwife, we use a total enumerative sampling to recruit all the midwives in the maternity unit for the study. Next slide. So the research instrument that was used was a structured questionnaire that consists of 2 parts. The section A elicited information on the socio-demographic characteristics of the respondents, whereby the section B was a secondary traumatic stress scale that was adapted and modified to suit the contents of the research study area. And this tool was a 20-item tool that offers responses ranging from not at all to extremely distressing, and a score was assigned from 0 to 4. So this tool was adapted and was utilized for the study. And then in the tool, the symptoms were grouped into 3, and these symptoms were emotional symptoms, the cognitive symptoms, as well as the behavioral symptoms. So for the validity of the study, a phase and content validity was used. For the first validity, the questionnaire was being compared with the aim of the study, and for the content validity, the same questionnaire was sent to 3 jurors from across the 3 Nigerian universities to rate the questionnaire for relevance, simplicity, clarity, and ambiguity. And each item was assigned an A for relevance, and that was also equally done for clarity, for simplicity, and for ambiguity. And then items that need modification were assigned B. So their final input was being looked at, and the draft was made before it was distributed to the respondents. For the reliability, 10% of the was used in a hospital about 50 kilometers away from the study center to distribute it to the midwife, and a Cronbach alpha of 0.80 was gained, which shows that the tool is very reliable. And the choice of using the hospital 50 kilometers away is to prevent contamination of the data. Next slide. So, next slide. Okay, method of data analysis. The data was obtained and entered, cleaned and analyzed within statistical package for social sciences version 27. Descriptive statistics were used to enter the respondents' characteristic and perceived psychological effect. Continuous data was presented as mean and standard deviation, while categorical data was presented as perceived effect. And then chi-square test was applied to determine association between selected variables at a p-value of 0.05 level of significance. Next slide, please. Next slide. Next slide. Okay, for the ethical consideration, an ethical clearance number was sought from the Niger State Ministry of Tertiary Health, An additional communication was made to the head of the maternity unit. The brief aim of the study was done with them, and then they introduced the researchers to the respondents, and the participants were given an informed consent form to fill before the process began. Confidentiality was also assured and upheld, with all provided information treated with utmost discretion. Next slide. Next slide. Okay, so this is the result of the study. You can see that the socio-demographic characteristic of the 160 midwives for the age, the mean age is 36.1 mean age. And then for the years of experience, the mean is 18.31. Next slide. Next slide. Okay, so this is the psychological effect of the traumatic childbirth. This table presents the symptoms that I told you were grouped into 3. That is the emotional symptoms. It's the one that have the highest mean of 4.3, followed closely by the cognitive symptoms with 3.9, and the behavioral symptoms has the least with 3.1. Then the aggregate mean score is 3.4 in all. Next table. Next page, please. So this is for the psychological. Okay, this one is comparing the association between some socio-demographic variables with psychological effect of witnessing traumatic childbirth. And this table, as you can see on the screen, has shown that there is significant effect between the age, between the years of experience, the word of posting, as well as the monthly number of deliveries, at a significant p-value of 0.012, 0.021, and 0.024 respectively. Next slide. Next slide. Okay, for the discussion, the study, as I earlier mentioned, was on the psychological impact of witnessing traumatic events. The results revealed that the midwives are exposed to secondary traumatic stress because the mean value was high, that is 3.4. This indicates that midwives are having a frequent psychological symptoms as they work in their unit. Then for emotional symptoms, they were prominent, especially feeling upset when reminded about the traumatic event, as well as reflecting as intrusive symptoms. This aligns with studies of Beck and Shin et al. And then midwives, they have been close to the women during childbirth, contribute to feelings of helplessness and emotional exhaustion, consistent with studies in Turkey by Chakanya, as well as in Ghana by Fontaine Kupchas, not Ghana, Netherlands. For the cognitive symptoms, it included negative belief about self, and also professional confidence, loss of professional confidence, often linked to self-blame and unsupportive work environment. This finding was also inconsistent with the studies of Mini, Cardell, Musa, and Bazara et al. Next slide. Next slide. Okay, for the behavioral symptoms, avoidance behavior was seen as the most accepted behavior, as the most accepted psychological impact. This avoidance behavior reflects a maladaptive coping strategies that is associated with secondary traumatic stress and post-traumatic stress disorder. This finding aligned with the study of Sapa, Dagi, and the Bingle in 2023. So for the association, it was found that some of these socio-demographic characteristics, the years of experience of midwives in their work environment have a cumulative exposure, as I earlier mentioned, with a p-value of 0.021. And then the word of posting equally, especially midwives in labor ward, are mostly affected because of their frequently contacting or coming in contact with women that have traumatic experiences. So these midwives are always with them. So they experience these symptoms the more compared to their counterparts in antenatal unit, in the postnatal unit, and the gynecological ward. So the high delivery workload is also equally linked with burnout and stress. So in conclusion, the finding demonstrate that traumatic childbirth is very profound and it has a psychological impact on midwives in Niger State. While consistent with evidence from other regions of the world, the system, or let me say this, the impact is worsened by factors such as systemic weaknesses, cultural stigma, and lack of institutional support. This underscores the need for intervention such as counseling programs, debriefing, and peer support system to safeguard midwives' mental health and improve the quality of maternity care. Next slide. So for the recommendations, the study came up with the following recommendation. One of them is institutional mental health support. The healthcare facilities should provide a routine psychological support for midwives. This should include assessing experts in counseling and mental health services, structured debriefing mechanism, so that as the midwife experience the trauma, there should be the briefing session for her as she processes the experience in a supportive environment. Trauma-informed training, midwives will have a continuous professional training in trauma-informed care and how to cope and develop resilience and psychological preparedness. And then there should be reduction in the workload by the hospital management, especially midwives in labor room. There should be a routine rotation of these midwives so that they can have a lesser place where they witness traumatic effects. Next slide. Thank you for your time and thank you for listening. The following slide is my references. Thank you very much. Professor Ada, over to you.
Thank you very much, Amina, for such a lovely presentation. And thanks to all our participants for joining. Please keep your questions coming for Dr. Amina to answer. I have some few questions here as participants prepare for their questions. I want to know, why was a cross-sectional study design considered appropriate for this research, Dr. Amina?
Okay. The reason for adopting the cross-sectional design method was because the study, looking at the aim, it tends to assess the traumatic events as they occur. That is the current psychological effects that the midwives experiences. And if you look at the cross-sectional design, it's a design that sought to the researcher will collect data at a particular point in time. So because the researcher
Have we lost Dr. Amina? Okay, as we wait for her to reconnect, thank you all for attending. And
can you hear me?
Yes, you're back online.
Okay, I said the reason for adoption of the design was because the researcher tend to collect assess the current psychological effects, and cross-sectional design allow for that, as well as estimation of prevalence of the occurrence of the psychological effect. That's why I decided to adopt that design.
Okay. And what are the key psychological effects identified among midwives, and how are they categorized so that maybe those who joined later can have that briefing?
Okay. So the key psychological effects, as I mentioned earlier, were the emotional symptoms, which has the highest mean score. And then it was followed closely by the cognitive symptoms and then the behavioral symptoms. And then for the emotional symptoms, they were displayed as stress, feeling of anger, as well as guilt among the midwives. For the cognitive symptoms, the midwives sometimes blame themselves for what has happened, most at times. And then this leads to poor concentration because of the higher workload in the maternity unit. You find out that before the midwives were able to process the traumatic childbirth, another one is coming, and there is no supportive environment. So they always blame themselves for its occurrence. And then for the behavioral symptoms is the avoidance, as I mentioned earlier. I said they tend to avoid, and then this avoidance is a maladaptive behavior which may tend to increase the psychological burden on the midwives. Thank you.
Thank you very much, Dr. Amina. Margaret says that interesting study, well done. Yes, this is very, very important as the mental health of midwives need to be considered after all the experiences they have, because mostly our attention is patient-centered and we tend to forget how the midwives also feel. My last question, as we wait in case anyone has another for you, what are the implications of the findings for maternal healthcare system in low research settings like Nigeria, the low middle income countries? What are some of the implications of these findings?
Okay, so the implication of the findings, as I mentioned earlier, I said there is high psychological burden on the midwives. And then this might affect them, whether they face the reality or not. As time goes on, it will affect them by bringing about reduction in the quality of services they rendered to the mothers and the baby. And then if there is reduced in quality, there is high chances of committing errors in caring for the baby. And then sometimes you find out that increased workload and the withdrawal syndromes or the avoidance syndromes may lead to midwives trying to leave the work entirely or move out of the country for a better, greener pasture. So these are some of the implications, especially in low and middle income countries, which makes the study very important. And then it's very important for our government to make sure that they provide a comforting environment, especially for the midwives, so that they can process the trauma as they witness it. Thank you.
Thank you very much, Dr. Ahmad. Aisha says, very interesting. Well done, doctor. So we'll continue with the session. Thank you to everyone. Don't forget to send your selfie for attending the section to us via info@vidm.org. And also kindly scan the barcode to be able to give us your feedback. In case you're using your laptop, you can use your phone to scan. But in case you're using your phone, we have the various links essential to the section in the chat, which has been posted. Don't forget to also download your certificate. You can scan the certificate of attendance and input your name as you wish. You can, when you log in, you're going to find the different languages. Arabic is there, so my Saudi colleagues can easily put in, take the Arabic version. Check out this year's poster by scanning the barcode on this side as well. And then please, you can log out after this section and use this barcode to also get to the next session. We really appreciate your feedback. Thank you for joining us. And in case you use your phone, kindly use the link in the chat to be able. Okay, so we have Felix who wants to ask a question. I think you can unmute yourself and ask a question, Felix. I think that should work. Is it possible? Hi, Felix.
So let me.
Okay, so okay, Alima,
yes, I'm trying to do that.
Okay. Please give us a minute. You'll be able to unmute.
Yeah, so he can do that now. He can unmute now.
Yeah, Felix, please go ahead. Kindly unmute and
Hi.
ask the question.
Hi. Thank you, Doug. Maybe I'm not coming from the health sector, so maybe my questions may in relation to the presentation. I wanted to know from your results. You said it was consistent with studies done in Ghana and Turkey. One of your results, I wanted to find out if there was any findings which were peculiar to your case study area that was not related to the literature that you've done. Maybe other studies have been done in other countries, but in your findings, was there anything that you found that is peculiar to your area which was different from what has been done so far?
Thank you very much, Felix. Dr. Ahmad.
Okay, thank you for that wonderful question. It shows that you are really following us. And you see, as I mentioned in the statement of the problem, I said that the empirical studies on midwives' mental health is not so many, it's not common, especially in Nigeria. I can say that my study is second to Professor Halima, looking at the trauma midwives goes through after witnessing traumatic childbirth. Most of the studies, you find out that they are on the mothers and the baby because it affects them directly. But being that the midwives are there when this thing occurs, they also share in this trauma. So there are a few studies. I think it's only one study in Ghana. And then most of these studies were conducted in the developed nation. And even in the developed nation, there are very few. So considering the fact that there is a greater disparity between developed and underdeveloped nation, you find out that the findings are almost similar. But I decided to now come down to my zone, which is the West Africa, where Ghana is, and I use the studies in Ghana, and it is similar. It was stated that there is a higher psychological burden faced by midwives, especially in terms of burnout. So the similarity of this is almost the same, even though there are fewer studies within the country. I hope I have answered your question.